So again, my name is Dr. Jaylene Sims, and I'll be the moderator for our maternal health panel discussion today. I'll first start off with a brief discussion of myself, and then I'll give an opportunity for each of our panelists to just say a brief discussion of who they are and where they are in this maternal health space. So I'm a board-certified OBGYN at Jackson Hines Comprehensive Health Center. I'm also the Associate Program Director for Wellness in Diversity, Equity, and Inclusion at the University of Mississippi Medical Center. And I'm also the State AIM Clinical Lead for the state of Mississippi, so at the Mississippi Department of Public Health. We will go ahead and move to Dr. Collier.
Hello, everyone. My name is Dr. Charlene Collier. I'm also a board-certified OBGYN. I own a practice in Ridgeland, Haven Women's Health, that just opened in October. But prior to that, I was one of the directors and chairs of the Maternal Mortality Review Committee at its inception in 2015. And really, like Jaylene, I think, and all the clinicians here just came into this field dedicated to improving maternal, particularly Black maternal health outcomes in any way I can. So very happy to be here.
Good afternoon, everyone. My name is Courtney Mitchell. I'm currently assistant professor of maternal fetal medicine at the University of Mississippi Medical Center. I am a native of Itta Bena, Mississippi, and so I've been back in the state about 3 years now. I am currently the administrative chair of the Maternal Mortality Review Committee, and I oversee case review for maternal mortality in the state. And so I'm so happy to be here and discuss ways we can improve outcomes for our mothers and subsequently their children here in Mississippi.
Good afternoon.
Good afternoon.
Thank you to the Glenn Foundation for my presence here today. I am Arletha Howard, and I serve as the project director for Tougaloo College Delta Health Partners Healthy Start Initiative in the Mississippi Delta. We're a home visiting program. Our overall mission is to decrease infant mortality. We're nurses, social workers, community health workers, and fatherhood practitioners that home visit prenatal women and their babies and their co-parents. And I also serve on the Maternal Mortality Review Committee. Thank you.
What a wonderful occasion. I'm so glad to be here with such an esteemed panel. I'm Dr. Latoya Mason Bolden. I'm a board-certified anesthesiologist with specialty in OB anesthesia, and that's really what poises me for this conversation. I'm a professor of anesthesiology at the university, completed a fellowship at Baylor College of Medicine, where I was on faculty for about 10 years before relocating to my home state, and it's just really been an honor to be back at home and try to be a part of the work to promote birth equity and help our mothers to do better. I am our state's representative for the Society of Obstetric Anesthesia and Perinatology, and I also serve along with these ladies on our state's Maternal Mortality Review Committee, as well as some of the work with the PQC.
So according to the CDC, in 2021, there were over 1,205 maternal deaths in the United States. 1,205 maternal deaths in the United States. Mississippi had the highest maternal mortality rate in our country, with a rate of 82.5 deaths per 100,000 live births. We're not the largest state. However, we had the highest maternal mortality rate. Black women died 3.5 times more than white women of that particular year. Black women do not account for the majority in the United States. However, 3.5 times higher is what we died. I'm saying it very slowly because I want that to sink in. Let's take it to the state of Mississippi. Per the Mississippi Mortality Review Report, in 2020, there were 48 maternal deaths. And that year, we were 4 times more likely to die. Our rate was 4 times higher than white women. Over a 5-year span from 2016 to 2020, there were 167 maternal deaths. 80%, y'all hear me when I say that, 80% were considered to have been prevented. That's 133 mothers that could still be here with their babies, their families, and their friends. 133 mothers who could still be living out the dreams of their lives. 133 mothers who could have contributed as productive members of our society. 167 mothers who took their rest way too soon and left their children motherless. May we take a moment of silence for these mothers and families. Okay, thank you. So I want to start off by asking a question to clarify MMRC. So to our panelists, what is MMRC? Y'all hear these letters. We say them, we roll them off, we know what they mean, but what is MMRC and what how does it operate?
Okay. Thank you, Jaylene, for that very powerful reminder, because when we think about these statistics, these are people, and Mississippi's small, and I can guarantee you know someone who knows someone that's lost someone. Mm-hmm. And so this is real, and every time a family member or friend becomes pregnant, they are at risk of this happening, because, especially if you're a black woman here. But it's not only black women, but because Mississippi's rates are higher than every other state, right? And then United States is higher than many other countries, right? So really, we're not doing well at all. Even when we're looking at our states that say that they're better, they're doing way worse than other countries. And we know this is not a biological thing. We know this is not a genetic thing. We know this has its roots for black women in racism and our generational history of not prioritizing the health of black women. And this is really the culmination and the realization of what happens to human bodies when they're not valued, and what happens to human life when it's in health when it's not prioritized. And then you will see outcomes like this. You do this to any human body year after year after year, generation after generation, you're going to see the same statistics. So that is an important point. So when I was on the Maternal Mortality Review Committee in the role they're on now, it became very important to understand more than the numbers, right? When we say a X percent or X number die, you don't know what happened. Those are just statistics. You could say X number died from hemorrhage. Okay, we know they bled, but what actually happened? What was the story that took place from the beginning of that person's pregnancy, really their life, what was going on with them, their care, and then how did that death actually occur? And you really need to know the data and need to understand the story behind that and understand what were the contributing factors. So that's ultimately what the effort behind an MMRC is. Mississippi had statistics for many years. This wasn't, the current MMRC is not the first one. There's actually been one for decades, but they weren't getting the depth of the medical records because hospitals weren't necessarily required to provide deep medical records so they could be reviewed from start to finish. And families were not being interviewed. That was an important addition that was added in recent years, that we actually talked to those families to find out, you tell us what happened. Because the medical record is not a reflection of the story of that person, it's a reflection of the story of the health system and doctors. And what we decide what happened and want to write down, it does not reflect what a person is actually feeling. So the MMRC is meant to categorize deeply both those statistics at that high level and then really review each death and identify the cause of the death. Is it pregnancy related, and were there contributing factors, and importantly, is it preventable? And this is not to take doctors to jail, it's not punitive, it's really the goal is to find solutions.
I agree with everything that Dr. Collier said. So the job of the MMRC is to really dig deep into what happened so that we can provide information to policymakers, legislation, so that we can make changes systematically that will impact mothers and prevent deaths in the future. And so when we look at these cases, we try to de-identify, so we don't know exactly where where this case came from. We just want to know what happened. And she mentioned the importance of we call them informant interviews, where we get the stories of the survivors of this tragedy, right? So we may interview a mother or a spouse or a family member, so we can understand what were the surrounding circumstances related to this death, because that gives us good context about other things that we may not see when we get the medical record. And so the MMRC's responsibility is to tell how this happened, but also to make recommendations so that it does not happen again.
And I'd just like to add, I absolutely agree with everything that's been shared. But, this concept of maternal mortality review committees is not new, but a new finding. In recent years, very recently, the CDC has rolled out their Maria program. Dr. Collar and I actually had an opportunity to attend in person several years ago in Atlanta. And what it has brought to the table that was not there before is a standardized application that every state, that has decided to participate in. We all look at these deaths. We all examine these deaths in the same way. And so anytime you do that, all the researchers in the room know that brings strength to that database, and it allows us a common ground, a way that we can all kind of, consolidate our findings, compare how things are same or different in various regions. And I just want to add that I really appreciate how Dr. Sims asked us to make that moment of silence. And that's something that Dr. Mitchell and Dr. Owens, Dr. Collier, when she was our chair of that committee, we always would start the meeting with that hard stop, because it's so important to remember that, like you said, these are all individuals. And where I'm going with this is that, it's hard work examining this. It's very stressful. I remember I was carrying one of my babies at one of the meetings, and it's very hard work, but it's sobering, but it's necessary. And I just want to remind everyone of what's been shared before, the power of resilience. We've heard that word this morning. And UMMC actually has the RISE program. It's called Resilience in Stressful Events, because as we all look at these, we want to make sure that we're not, we can become a second victim. And so it's important that we have appropriate coping mechanisms and healthy ways to do that, because we want to look at this work, but we do want to continue to launch ourselves forward and stay safe for ourselves and our families.
I just wanted to add that also an important part of the MMRC is to be the voice for that lady, to help her family understand and what the community understand, and take that educational, preventive message back to the community, how we could have helped that mom or some other mom still be here.
And I'll add one final thing. The MMRC is not just made up of clinicians or physicians. We have a multidisciplinary team, community members. We have law enforcement representatives. So it's not just the clinical aspects of it. We had a lawyer on our team who talked all about like trafficking, because we see a lot of issues related to drugs and mental health and sex work and trafficking in our committee. And so it's very important to have different voices from different perspectives on the committee, because that brings a more robust discussion and examination of the case. So it's not just doctors on the committee who are doing, deciding is this what happened. It's other people who don't have medical backgrounds at all who help enrich our discussion and our decision making.
I'd just briefly add that when you hear the word preventability, people often go straight to something the doctor or the nurse at the hospital did, like they didn't medically do something to save that life. And preventability goes much broader than that. You can think if there is a mother whose insurance ran out at 6 weeks and she died at 8 because she didn't want to go to the doctor because she didn't have insurance, that's preventable, and that's more of a political determinant of health, which we remember Dr. Dawes was here, I believe last year, was an amazing speaker, and that's a great book, The Political Determinants of Health. Or if that person's hospital shut down in their community and they had to drive 2 hours to get to the nearest hospital and they died along the way, which has happened, that is yet another didn't even get a chance to go to clinician, but was preventable because community was not informed that that hospital was closed. There is no transportation for that person. So these preventability goes way past clinical one-on-one care and really looks at how our society is structured, our policies are structured, what is going on in the community, and really looking at all the ways that a death could have been prevented, even going back to the full life course of that person. Because if they are being raised and living in an environment that has always had potential negative health impacts, we always talk about the patient. Well, she's obese and she has hypertension and she has diabetes. Well, she lives in a neighborhood with no grocery store. She has to get her food from a gas station where it's a food desert. She has no safe parks to go into. So what else would you have expected in that situation? And whose fault, or what is the preventability there when her blood pressure is out of control, when she has no doctor nearby? So the preventability goes way past that, but often people hear, and rightfully so, there are some clinical things that definitely go into it, but it really does break it down, and the committee does a great job with really laying that out within the report.
That was a very, very good point. Social determinants of health. Everybody hears that comment all the time. She broke it down for us. The social determinants of health. So I quoted some stats a little earlier. I said black women die 3 or 4 times more than white women, and in some instances, even 5 times more. So my question to you all is, why do you think that is? Go for it.
So this is a very hard question, right? But it's not that hard, really, because I think it really boils down to racism and systematic biases in our system, that we've lived in conditions that are not ideal, right? And those things have gone through generations. And I think now people are saying racism out loud, right? But it's still a lot of pushback against that, right? Like, people don't want to say that because they're fearful that they'll hurt someone's feelings, or feel like if I say this is a racist issue or there's racism in it, I'm not saying you're personally racist, right? But this is the system we live in. And so I could go on about social determinants of health, but I think if we aren't honest in saying the racist parts of that, we won't get to the bottom of it. I think there'll take years and years and years to get changes that are needed, because we need better education, we need food security, we need housing security, we need more doctors, black nurses, black midwives. We need to teach, children at an early age what they can eat, what they can't eat, but they need to have access to those foods. So it's a very hard question to answer because it's so many aspects that need to be addressed. But I think racism is at the root of all of it.
To add, as a home visiting program and being in the community with boots on the ground and witnessing a lot of the challenges that our moms experience day to day, and knowing that they will go in a clinical setting, they're not going to share what's happening. They're not going to say, well, I didn't make it because I didn't have a babysitter, or I didn't make it to the appointment because when I got a ride to the doctor's office, they gave me a prescription for my blood pressure, but I couldn't go get it because, they wouldn't take me over there, and you go back out there and she still has the prescription. So I think more coordination would help a whole lot, but then also that education, that advocacy piece, teaching our moms to use their voice.
I just really echo everything that's already been shared. We talk a lot about education, and education is so important. And when we say education, not only is it important, for the patient, and when I say education, I mean, to make an informed decision, to have the information to make an informed decision about what's best for them. I teach the resident physicians that I work with, let's meet the patients where they are. That's different for everybody. When we think about equality and equity, everybody in here has on shoes. They're necessary to walk in here, but we all have on different sizes of shoes. And so, when I teach the residents at the university, we're really trying to identify, how can we better meet this patient? And so, sure, education for the patient, but also education for providers. We talked about these implicit and explicit biases, social constructs. Well, as providers, we need refreshers or new information on, how to really perceive a lot of the information that we're getting, because all of that plays into this issue of why care is so disparate.
Of course, yeah, I definitely echo all of that. And there's so many wonderful books out that I encourage people to read. If you read Medical Apartheid, Medical Bondage, Killing the Black Body by Dorothy Roberts, all of these texts really lay it out very, very clearly. And I think no one can deny, when you look at the system of chattel slavery in the United States and the fact that black women's bodies were essentially an economic engine, and the proliferation of birth was really about using black women's bodies to create an economic system. And then once that stopped and Reconstruction was going on, I always ask, well, what happened to fix all that harm, right? If there's all this harm and all this damage that was done, and then it stopped, it's down here, right? So where was the point in history where we did a big correction, where there was a huge investment, where there was a huge healing, where there was a huge reversal of trauma? And I was listening to a woman speak about just mental health trauma, and like, when did the therapists get flooded into the black community to help with the trauma of what was segregation? When did that happen? When did the hospital investments just flood in for the communities that didn't have one? When were the medical schools funded in large number to bring more health doctors? They were actually shut down by, many of the black medical schools were shut down when they were proliferating. So many people are like, well, like, slavery's over and all of that is over, but yes, it ended, but then when was the healing and the correction? So it did not happen to the same intensity that harm took place. So we're always trying to chip away in little corrections, but there was never that flood of an improvement. So yeah, once you start down here, and then you stop the insult, you need the healing, and we just have not gotten there yet. And you just see the reflections of that in the community. But, and I would say now another area where we may not be able to outright discriminate. People say, okay, you can't discriminate on race anymore. That's the old thing. But what about by insurance payer, right? What about, is it okay to give less time to a woman on Medicaid when a doctor's not being reimbursed the same to someone who's on Blue Cross because they're being reimbursed higher? Is that okay? Like, they deserve more because they're paying for it through their job versus it's a state program and they're getting it for free? Like, so then it becomes okay to say, oh, you can get less time or you can get less attention, right? Because it's based on money. You didn't pay for it. So it becomes a justified form of discrimination when you start to look at who is more on those types of programs, right? Tends to be more black women here in our system. So you see these differences. There's whole OBGYNs that don't take Medicaid, right? People in that neighborhood. In Jackson, Jackson, Mississippi, right? Which is a predominantly black city, last I checked. Most of the people on there, most of the residents in that city are on Medicaid, and there are OBGYNs who work there who do not accept Medicaid. So what does that person have to do? They come to see you, they'll come to see me, and then our doors are flooded, and we get less time and burnt out, and and the cycle continues. So, I mean, like I said, it's a difficult question. Nobody wants to hear the answers. It's like challenging, but it's very in plain sight why this continues to happen.
So you all have alluded to this question, but I want to see if you have anything to add to it. Why is Mississippi the highest? Why are we the worst? Why are we the worst in the country?
Mississippi can be a bellwether of sorts for the country, right? If it's happened in Mississippi, it's going to happen other places. And I think the South gets a bad rap because everybody thinks it's so bad and it's so dysfunctional. But, it's just a representation of our entire nation. So Mississippi, yes, we get labeled the worst, but we also have a very strong history of slavery, racism, and systematic oppression of people of color and black people in particular. And then we also have ongoing barriers to progressing from a policy standpoint to allow for people to have equitable care, equitable jobs, pay, education. And so I think that it's just a manifestation of continued systemic racism in the state. But I don't think that it is unique to Mississippi. I just think that it's a representation of the nation as a whole. And I think we just are, the worst manifestation of it. But I think it's the same things that we've talked about already. It's just poor education, and the impetus or the will to change from the people who are in charge is more difficult.
We also have to look that in some of our communities, there is no maternity care.
Right.
How you gonna get there? And then if you're high risk, you may have to leave the state. Depends on where you live. And that creates an additional challenge for a positive birth outcome and for mom. So, because I can tell you, we're in 7 counties, and 3 of our counties are maternity deserts. And so a lot of the high-risk moms travel to the neighboring state for high-risk care. Yeah.
And I'm from the Delta, so growing up, I was born in Greenwood, right? So Greenwood LaFleur Hospital is a hospital in Greenwood. We had a delivery service, OBs. That hospital does not deliver babies anymore, right? So my town is about an hour and a half from Jackson. I see many people from my community in my clinic weekly who drive or take transportation to my clinic. And it's difficult, right? Like they can't, say for instance, they have a 10 o'clock appointment or 11 o'clock appointment. If they're coming by transportation, they have no control over what time they're picked up. They can't bring children to the clinic. They don't have control of when they will get home because they come to their appointment, they may be with other people, but they have to go pick up other people. If I say your blood pressure is elevated, you need to go to the hospital because I'm concerned, then we have to call the transportation service to try and see if we can change the route so they can get to the hospital. If not, then I have to call the ambulance, which is, misuse of resources because it's not an emergency, but we need them to go. So they may say, I can't come today because I don't have transportation. Transportation never came. And so it's these issues are examples of how the system just does not work for our patients. And then again, if you grow up in a place where you don't have, access to healthy foods, and if you do have access to that food, you don't know what is healthy because of the environment you've been in all your life. And trying to fit all the things I need to tell my patient in 30 minutes, which may be an hour sometimes, but 15 minutes, is impossible. And then the other thing is, like, if they have Medicaid, they only have so many medicines they can get in a month sometimes, right? But if you have high blood pressure, you have diabetes, you have depression, you have lupus, I need to give you 7 medications, and you've already run out of your Medicaid allotment for the month. So, and then you send to this pharmacy, they don't have it, and it's closed. So it's just levels and levels and barriers and barriers and barriers to getting the care you need. And so I think that we have to do a better job of, and I'm a clinician. I'm not a politician. I am not a legislator. I'm not an epidemiologist. I'm not a community worker. I can just see what's in my clinic. But we have to work with all those people so that we can figure out how to get people what they need, because me telling them what they need to do is not going to work if they don't have the environment to support that.
So in your opinion, we've talked about the problem, right? We've put it out there. In your opinion, what critical factors would you see to be necessary in order to create change in this system?
Well, Dr. Howard, Arletha has a great program. It should have been all over the state probably 10 years ago already. Like every county, you have 7, right? Like should be all over the county. Mississippi, even though we also talk about it being a rural state, making it difficult. We have the highest C-section rate in the nation. And they've looked at it every which way, and it's not because of obesity or high blood pressure. There's also a way that health is practiced here that leads to some of these outcomes. And we know that midwifery care has lower rates of C-section and better birth outcomes for low-risk people, right? Because we're busy, stressed out about high-risk patients. Maybe we always have our high-risk hat on. Maybe we're always stressed out, too, as clinicians. And when this very low-risk person comes in, we're in a rush. We're pressured. We are crowded in this system. There is enough space, trust me, for midwives to practice in Mississippi, and there won't be a drip miss from doctors. But yet there is resistance to that. And community health workers. Doctors are not the solution to everything. I'm not coming to your house. I'm not. I can't, right? We're too busy in clinic or the hospital, but we need home workers. We need people in the community. So I think, you know, liberating who is there to do actually make an impact. That concept is not just clinical. It's not just clinical. You need mental health workers. You need community. You need just that person to say, come on, let's get up and go to the doctor. I'm going to hold your hand. I'll go with you. That person is necessary. Because if that's the person that gets that woman out the house to the doctor and we find a problem, she's the one that really saved their life. We get the credit when we catch the problem. But really broadening who is considered a health team member, because they're in the communities right now. We don't lack that. So I hope we could start to see a greater expansion of our workforce and the workforce that looks like the community that they're caring for. And we need these pipeline programs to build up. We have great HBCUs. We should be seeing graduation rates going into the medical field across every specialty. And that's something we can do.
If every single one of my patients could have a doula, I would be so thrilled. I just thought I'd throw that out there. If every single one of my patients could have a doula, it would just be outstanding because they have access to information about birth plans. They get that education that we don't have an opportunity to do every time in clinic. They can answer questions that they may have forgot to ask me in my clinic. I mean, what you said was right on point. If everybody could have a doula and a mental health specialist, even if you don't have a mental health condition, you still need to be able to talk. When's my next appointment? Because I got one coming up. I'm telling you, we just need to be able to talk, release the tension and things like that. So yes, that was it right there.
And you know, as we continue to kind of brainstorm and talk about possible problems to this awful solution that's much bigger than all of us, but working together, hey, together everyone achieves more. We think about these maternal deserts and lack of access to care. And I can't help but think of COVID as awful as it has been. I do think there's some good lessons that came from it. Specifically, I'm thinking about the role of telehealth and telemedicine. And definitely our institutions, our communities, we need to work with our lawmakers to figure out ways to make sure everyone has a Wi-Fi connection. And, you know, because that can represent a way that we can connect with our patients, not only for, you know, how well they're doing during their pregnancy, but this mental health thing that's coming up, you know, how are you feeling as well? Because those are some things you can achieve with FaceTime, you know? And so I just wanted to mention that.
I'll add a couple of things. So number one, I think one of the things I see in my patients is we recently in the state of Mississippi expanded postpartum Medicaid for 1 year, which is a big deal because what happens is you have extremely high-risk patients who have multiple comorbidities or multiple medical problems that you're caring for intensively while they're pregnant. So I'm seeing them every 1 to 2 weeks while they're pregnant. They have a baby. They may stay in the hospital. They may come back 1 or 2 weeks later, and then they come back for their 6-week postpartum visit. But then they are lost, right? So they go back into their community. They are not receiving adequate care for their medical problems until they're pregnant again, right? And so now you compounded whatever happened in the previous pregnancy. You're pregnant again. And if they don't get pregnant again, they may not be seen until the problem is so bad that they have to present. So at that point, it's too late. And so I think extending postpartum Medicaid has been excellent, but I think the next step, which we're getting more traction on, is extending Medicaid period in the state of Mississippi, right? Like a lot of states have expanded Medicaid, and we see the benefits of that, and I think that's very, very important. And then I will say for community health workers and home visiting services, my aunt worked for Delta Health Alliance, which did a home visit study. And so she was just a support person for pregnant women. And, you know, she had a log of patients she was seeing, and she was supposed to ask them questions about their baby developing and all of those things. But she was way more than that. Like, they called her when they needed a ride. They called her when they needed money. If they had a problem with their partner, she was getting it all, right? Like, she became their go-to person, their support person. And I think programs like that are so important because these are people who live in the community, who know what the patients are going through. Um, but I think expanded Medicaid will be a big help because it'll um, provide the care inter-pregnancy because patients are just, you get their A1C down to 7 when they're pregnant. The next time they come back, it's back to 12, and so it's the gaps in care because people don't go to the doctor because they don't want to pay for it. They don't have money, and they don't want to, have that extra burden and, another bill on top of the bills they already can't pay.
So one of the other things that I wanted to mention that hospitals are doing is a program called AIM. So earlier when I introduced myself, I said I was the state AIM clinical lead. Well, AIM stands for Alliance for Innovation on Maternal Health. So it is a program that has these quality improvement bundles or safety bundles that hospitals are to roll out to help remove the bias in care in hospitals, and also to help basically teach providers when they see these particular signs, this is how you react. And so that's one of the things that are also being done, and we're trying to get every single hospital in our state on board. And at this point, we've done safe reduction of cesarean birth. We just mentioned the highest C-section rate. Postpartum hemorrhage. We've also done hypertensive disease of pregnancy, and we're currently rolling out one called the postpartum discharge transition bundle, which I really feel like will be a game changer for us because, as Dr. Mitchell just mentioned, they go home, they go back into the community, and they get lost to care. So it's a great opportunity for the obstetric providers as well as the primary care providers that are in family medicine, adult medicine, to really collaborate to take care of those patients and have a good transition back into society. And so I just thought I would mention that as a part of that question that hospitals are working on currently. And then my next question to you all is, what advancements have you all seen that you feel like have some promise in maternal health?
I think one of the advancement that that we have started, thanks to Dr. Collier, and the blood pressure cuffs. When we meet a prenatal lady and we do an assessment and she's high risk, and she qualifies to get a free blood pressure cuff, we teach her how to self-monitor, record when to call her physician or go to the ER. That has helped tremendously. I think we started initially with only like 44 blood pressure cuffs, and just since last year, I think we've given out like 50. Yeah, and then we track that birth outcome.
That is awesome.
I mean, the hospitals have made a lot of changes towards a culture of safety and expectation that there are standards that need to be met for every patient when certain critical medical factors are present. So really, even if someone is biased, it shouldn't matter, because if someone's blood pressure reaches a threshold, you have to treat it because there's a protocol, there's an algorithm, it's known, it's educated, it becomes the culture that anyone can speak up to that derangement in that maternal health. And so that's really important, so that it can't be just one person's call that we're going to transfuse someone or not, or we're going to treat a high blood pressure. So I think that has become more standard and more aware that there are hypertension standards, there's hemorrhage standards. So that certainly helps in the moment of a severe issue. But we don't want to take people, of course, to that edge every single time, because people will fall off that edge, and that's who we lose. But beyond that, in the community and before, I have seen that proliferation of doulas, which has been amazing. I think there was a lot of pushback and animosity, when I first moved here in the state. Even to, you say you have a birth plan, like people would scoff at that, and they would be like, ugh, and get talked about. And I see that a lot less now, that it's more welcoming, even nurses getting trained in bedside support to expect that and listen. So I'm glad that is making some progress. We certainly still have a long way to go. where that information is available to everybody sooner. But I think the blood pressure cuffs help with that, and just ways to empower families to know what to take their own health into accountability and be able to speak up. But so those are some of the things I think have been promising in terms of the medical advancements.
Well, sure, and I think just as a society, we're going in the right direction as far as we have an awareness now, and we're trying to get the education out there. I mean, I think about my career that's spanned almost 2 decades now. When I would go to national meetings, we would never even talk about or bring up, you'd never hear the word diversity or equity or maternal health. And we're hearing that now. And 10 years ago, I wouldn't have come to a Dr. Glenn Foundation, the Glenn Foundation symposium. So thank you all for your vision and for just allowing us this forum. So I think it's important that we start to talk about it. We acknowledge, and guess what? Women were dying 10 and 20, 30 years ago. We just weren't talking about it. Dr. Beatty, I see your hand.
Yeah, I was gonna. Oh, go ahead.
Yes. Mm-hmm. Yeah.
Okay.
And then one other thing that I think has shown promise is something called group prenatal care. I was talking to somebody about this at the table. We don't do a lot of group prenatal care here, and before I came here, I was around a lot of group prenatal care, and we have data to suggest that it improves outcomes, especially for Black moms. And so there are models of group prenatal care where basically women are cohorted, so they're similar gestational ages. A lot of times they'll have similar demographics. And we, when I was in residency, as I was leaving, we modeled this in our high-risk clinic. So we put like diabetics together or people with chronic hypertension. But it forms a community, and I think people are more open to sharing because they're going through this with someone else. And I think that models like this are very common in midwifery, but I think expanding those for our patients would be helpful because they sometimes feel isolated and they don't feel comfortable talking to a medical professional, but they may be more comfortable if they're in a setting with other people who they feel like look like them, who are going through the same thing. So group prenatal care, I think, is something that's not new, but can be expanded and has potential to improve outcomes for moms.
I just want to add also, I think we've made strides as far as mental health screenings.
Yes.
Before, after pregnancy, if they're in crisis. I think people are sort of turning around and say, it's okay. It's okay. We're going to talk about mental health today. So.
Yeah, beautiful. So audience, I want y'all to be thinking about your questions because I have just one more that we'll just briefly cover. And then is there yes, there's a mic here. So if you have questions, go ahead and stand at the mics. That way we can make sure that as many people as possible can get their questions answered by our esteemed panelists. So what type of policies do you all see necessary to improve the outcomes of our maternal health crisis? Aside from our doulas and needing more nurse midwives and hospitals and deserts and.
Well, I mentioned like Medicaid expansion for our patients, but I think, in this new, in this time, DEI is kind of got a black eye, right? Like everybody's beating up on DEI, but I think policies need to be specific and targeting reducing disparities for Black people and not just being afraid to say this is for Black people. But I think people think that if I give something to someone else, it takes away from me. But I don't think that's the case. And like Dr. Collier pointed out, we have never invested in reversing the things that have happened to Black people. And I think that whatever policies we do, we need to have a lens of equity in it. But I think it's very hard right now because those letters are so, they're very stigmatized right now.
I think certain things like pay equity in terms of many women not being paid livable wages in our state. And so they're the ones on Medicaid. They're the ones that have to go back to work very quickly. They don't have paid maternity leave. So they're always up against how to, care for themselves is in a direct conflict with feeding their families or their own economics. So I think you'll see more if we're looking at investing in the economic stability of women in our state in particular, and for parents so that they actually have some time to be home with their children. Those are two policies: paid parental leave and economic equity for women are two things we could definitely think about. And so yeah, I just want to focus on that, just because as we see always chasing behind the lack of resources, and so in some ways many people perceive like, oh, these women on Medicaid are not working. They're all working. All my patients are working. I don't know about anybody else. And so when their employer does not have to pay health insurance, the handout's not to the patient, it's to the employer saying you don't have to cover health insurance, so they get that discount. But the parents are but their families then don't have the resources they need. So there are even policies out there in some states that are just giving cash to families and saying, here, there's one here in Jackson, I forget the name of it, but there's a really interesting program just giving, unfettered, unrestricted funds to families and during their pregnancies, and it's been showing better outcomes, because when someone is not struggling to put gas in the tank, their blood pressure's not going up, they're not worried about not, paying for food, paying for prescriptions. So just looking at that, those things that build up the economic stability, particularly of mothers and families in our state.
I want to add to what Dr. Collier just said about jobs. Some jobs don't even allow patients to get off work for their prenatal care. I have actually had to call to managers on jobs to ask them, what is it that you want me to write in a letter in order for you to excuse her for her prenatal visit? I'll get her in and out so she can get back to work. And I have been told it doesn't matter what you write. She's still going to get a mark or whatever you call it. It's like a mark or something. And you get your 3 marks and you're fired. So I've had patients miss multiple prenatal visits because they do not want to be fired from their jobs, understandably so. So policy could be very helpful in that area too.
This policy change, I feel that would help tremendously has to do with transportation, the limits of transportation. And I think if somehow, some miracle, it would change to reflect the needs of that family, that would help tremendously.
Mm-hmm. Are there any questions? Sure, please.
Thank you for your very beautiful presentation and your insight. So the question, I guess, I've had for a while is, what can we do? And I know that I heard somebody say that there needs to be education for our doctors as well, or our medical staff as well. One of the things I experienced during pregnancy was, I had a great physician. He was energetic. He even gave foot massages. He was just awesome, right? The works. But afterwards, after I was leaving one of my very last appointments, Dr. Llewellyn, I'll never forget him. After I was leaving one of my very last appointments, a young lady, she was 16, she came in with her mom, and the whole atmosphere of the clinic changed. The whole atmosphere changed, where they were very rude, they were very nasty, they were very, the way that they were so rude to her, I had to step back because I needed to see that, because every time I came in there, the attitude and the atmosphere was very cheerful, pleasant. And as I was leaving and they were walking in, it was more of a, oh, here she come. And I think I don't want to say who said it, but it was, she got Medicaid anyway. And so it was that atmosphere that made me take a step back and look at how and why some of our women don't want to, or even if it was a child, they might not have wanted to go back, or might not have wanted to go into that environment. So like I said, I know I heard you guys say that there needs to be education for our medical staff. Is there anything now, or, what's in the works?
So I think that medical schools, nursing schools, schools that train medical professionals are more open now to teaching about implicit bias that is required for residency training. I think that as time goes on, hopefully those types of things will continue to improve, where people have more open attitudes toward different types of patients, different people. But again, that's like individual, like it's a cultural thing, right? It's cultural, but it's also individual biases too. But I think that medical schools and in general have made many strides in trying to include diversity training, implicit bias training. I think that it's hard though, because some people take that as just, it's another module. How serious are they doing the work? But I think it's an ongoing struggle to try to implement the things that will make a difference so that people won't treat people badly.
Yeah, and I think I agree with those statements, but instead of always looking to change someone's heart, we just start building up the communities to train actual residents and staff and clinicians and more people who already have a heart for that community. I can't tell you how many people from Mississippi may come for, residency applications. They want to come back and work here and they don't match, or they can't find a job here and then they leave the state again. And so that happens frequently. Our medical school is a state medical school, so it has its own standards that you have to be, resident of the state of Mississippi to go to medical school here. There's not equal standards of that. It reflects the population of our state. And so how much work is being really done to train up students to enter our med school? I think it's only like 1-2%. Like, what's the percent of black med students right now at UMC?
It's getting
that are
higher
med school?
each year, but
It's getting higher, but it's still not
it's
reflective.
still-
And
yeah.
so more efforts to diversify, so people see someone that looks like them, they can relate to them. I think that's even more critical than trying to change somebody's mind about somebody. Unfortunately, that's kind of like what I think about how we raise our children, right? But yeah, I would just like to see more effort to see that there. But you're absolutely right. It is there, and there's nuances to bias. It is not always that everybody gets treated bad just because of their color. It may be the tone, it may be their wealth, it may be their money, and all those layers, their size, their age, as you pointed out. So there's so many layers to it, but that's where doulas come in, having somebody there literally who knows the system, who's seen many people get cared for, so they know that, oh, I was just with my last client, y'all were all smiles, and now you're not. And so they could kind of be like, well, you educated my last patient on this, could you do that with my current client? So there's ways that having an advocate could also help against those kind of scenarios. Question.
Can I just add something before the next question? And I guess I would be remiss not to mention this policy issue in the state of Mississippi about reproductive justice and abortion rights. And you can feel however you want to feel about abortion, but I think as a high-risk doctor in the state of Mississippi, I see every day the impact of not having decisions about what you want to do with your pregnancy in certain settings. And so as a physician and a clinician who takes care of people who are high risk, and those who may not be high risk but have terrible things happening in their pregnancy, the limiting options for women is a detriment to them and the community. And so I think policies that the policy needs to change about access to abortion care in our state.
Agreed. Yes, absolutely.
As we become more aware of Black maternal health issues and the crisis that we're in, what I'm observing in practice as a pediatrician when I'm talking with moms is a heightened level of fear about their birthing outcomes. So my question to each of you is, how do we bring joy into the birthing process for Black women?
Thank you. I love that question. That's why I opened my own whole clinic, because I was just tired of. I really was getting burnt out of death. I was like, death is that's the floor, right? Preventing death is the floor. That is the bottom. That should be the minimum that we are trying to achieve. It is actually thriving. It is actually positive outcomes. And the prevention of death is not the creation of a positive outcome. And a lot of people miss that point. I've had patients who I was walking in the office, and this was. I was still in the clinic with residents, and they sign out, well, she had a full-term birth, she had a vaginal birth, she's breastfeeding, she's a Black mother. I'm like, yes, this sounds great. She had a perfect outcome on paper. I walk in, and she's like, I'm never going to the hospital again. She said it was the most dehumanizing experience I've ever had. They made me push on this side. I couldn't do this. I couldn't see my baby for so many hours. And she just went on and on. But on paper, statistically, she was a perfect outcome for our state. Statistically, if everyone did that, we'd be top notch. But it was a traumatizing experience for her because, again, the prevention of a bad outcome is not the creation of a positive experience. And so if we start to actually centralize, and there's been studies on this, if you centralize the patient's positive experience, like if your bar is here, you already include not dying, right? If you make your bar like joy and happiness and fulfillment and a great outcome, that by default, you're not dead. So I think that should be where we look, where the metrics we count on our hospitals should actually, those Press-Ganey scores and stuff, which, sometimes they care about, sometimes they don't. But if we actually start looking at what we consider a positive outcome, not the prevention of death, but actually when people report, just like with the mortality review, I actually started driving my car. We should do a positive birth outcome review. And just if you had a beautiful birth experience, just tell us what happened so we can replicate that, right? We can replicate that over and over instead of trying to stop all the bad stuff. We don't really know that that person was like, well, when I walked in the clinic, everyone smiled at me. They were nice to my children. They let my children walk in the door. I've had patients get turned away with the baby I just delivered 2 years ago. No, ma'am, you can't walk in because you got a toddler with you, in prior settings. So that level of stress that creates. But that's a great point. We have to, I think now that we've settled into this mortality understanding, I think moving the needle is moving that goal to something better.
A lot of that has to also do with bedside manner of your clinicians from the top, your physicians, all the way down to your students. And, your student, your staff, every single person that's going to be involved with the care of the patient matters. Because those patients, they remember their names. And sometimes when they come back to clinic, they'll say, Miss Nicole, she was really, really nice to me. Or they'll say the opposite. And so that is where it comes from on our part to ask them, hey, what are your wishes for when you go into labor, or what are your wishes for this pregnancy? And when you begin to really hear them and ask them social questions, that's when their experience heightens.
And that's exactly what I was going to hit on. If we want to really talk about restoring the joy of pregnancy and really enjoying this beautiful gift from the divine that you're carrying, we have to give women the confidence to know that we are hearing them. We're listening, and when I think about the CDC's Hear Her, and how that's such an advocacy initiative, the Hear Her campaign, it's really, bridging a gap, helping women to know how they can communicate, how they can share their stories. And I'd be remiss if I didn't mention that I was honored to actually be a part of Hear Her, their campaign, a posting that they made just a couple of weeks ago. Because as well-connected as I think I am, my goodness, I'm an OB anesthesiologist, I found myself in denial about how I was feeling. Because as women, we feel like we're superheroes. I have to be everything to everybody. It's okay that I'm tired. I just had a baby. I'm supposed to be, I can't walk from my bed to my refrigerator. And I don't live in the Buckingham Palace, by the way, but I just don't feel like walking there, but I'm still in denial. And thank God for our moms, right? My mom, who's sitting in the room, was like, Mom, she was like, call your friend, don't you know some MFMs and cardiologists? And I texted a friend, and they were like, well, you go to the hospital. And I'm glad that I did, because I was in full heart failure, sitting at home, rocking my baby, singing Amazing Grace with an ejection fraction of 18%. And so I say all that to say that I'm so glad I had a chance to share my story. And if we let ladies know about these resources, then they too will know that when they share their story about how they are feeling, that they'll be heard and hopefully prompt action can ensue.
Okay. All right, so our time has expired. I see we have one more question I have to ask. Is it okay? Okay, please.
I'm going to make this very brief. So in terms of, I know we're talking about policy and advocacy, so I want to know, what are your suggestions for organizations who are centered in community education, educating the community on how to engage with policy, because we know we say policy and advocacy, but in order for something to become a policy, you got to get the lawmakers involved. So how are we engaging? What are some good messaging that we can use? Because we can't go to the community and expect the average person in Jackson or rural Mississippi to know what DEI is, to know what infant mortality, just though, because those seem to be buzzwords around organizations because they're in the work, right? So, but for the average person, what are some good ideas around messaging when you're in an organization that are trying to reach the community, that are in the community, educating people on how to get involved into creating policy? Because again, if the thing becomes a policy or a law, when we're talking about Medicaid expansion, when we're talking about all of these other programs that can be implemented throughout the state, how can we better educate those people so that they're electing officials who are caring about this and who are helping to make this? Because that's how things actually become like laws and put in effect. So are there any ideas around like messaging and communication?
I mean, I'd say taken from the lesson of the Mortality Review Committee, getting those stories is important. And many people don't know that their birth story has the fuel within it to share and say, this happened to me in your district, that when I went to give birth, that this is how I was treated, or I was not able to access care because of this. So you know, one person in the organization may know the policy that goes with it, but you need that compelling story, and the people have those stories. So just even talking and saying, tell me about your birth experience, tell me about your pregnancy experience, and I guarantee you there are all the examples you need to reflect on why a policy would need to move forward. The MMRC report has suggestions in it. You can get a copy, you can print it, you can share it with people, talk to them about how they feel about it, because really when, you know, you can share these statistics, say 70% of this or 80% of that, but you share one story of a person said, I thought I was gonna die and no one listened to me. I called for help and they turned me away. I went to the ER and they, you know, that one story should be enough to move change, right? Like my baby died when they told, you know, when I didn't get the care that I needed. That should be enough as well. So I would think, you know, connecting what the opportunities are. There are opportunities to go down on the Hill. There's days that they're advocates like the Black Women's Roundtable has a day on the Hill. We just finished, this is the end of Black Maternal Health Week, and certain states have formalized that into policy, so that whole week there's opportunity to actually educate legislators. So I certainly hope next year Mississippi could recognize Black Maternal Health Week as a place where you can actually educate legislators during that time. But starting with the stories and then using that as fuel to say, yes, actually your story could motivate change. That mother who can't get off of work, and say, this is why I didn't get to my prenatal appointments and we need a change for that. So that would be my suggestion. I know we're way over.
And then leveraging social media. We're all on our phones all the time, right? And so using what she's saying, like stories, put it on social media, asking people to share, like your friends, your family, to share these things, because a lot of times people don't have, like we're on our phones, we're on social media, but we use that as an escape, right? We're not like trying to get into the hard stuff. But because you don't feel like you have time, you got work, you got children, you got school, you don't have what you need, and so you don't want to focus on something that's hard. But when you show people that this can impact you directly, that's how you get people to engage, I think.
Okay. Well, thank you very much for each of your time, and we thank each of you for your questions and your attendance at this.